At the onset, I would like to thank Chitra uh, for letting me participate in this symposium. And this is your first symposium after the elections, and I'm the opening batsman. So I'm going to show two videos. Can I have my video on, please? So this is a first case of a simple procedure of hydrodissection and another case of meiosis during the phacoemulsification. So the first case is a hydro complication and how we get away with the problem. So as you notice here, my associate has done a CCC slightly smaller in size, about 4.5 millimeter in size, followed by hydrodissection. Please watch now the fluid wave going across, and I'll tell you when it goes. This is the moment you watch it, and that's the fluid wave gone. No decompression happened of the nucleus. And the second fluid wave causes the lenticular pressure to go up, and watch the rip that happens in the continuity of the CCC. Now that's in slow motion, and you can see at about 5:30 position, the CCC has given way. Now the question is, how is the situation? And has this gone equatorial or beyond that and caused a rent in the PC? So you reduce the bottle height as much as possible, and then go ahead and do phacoemulsification. You can see a sharp tip, a shining tip, and that's because it's a new tip. And now we are not going to phaco in the direction of the rip at all. What we are doing here is phacoemulsification with the chopper in the left hand and going ahead, occluding the tip, and then going ahead and gently rotating the nucleus. Once the nucleus is rotated, we bring it back to the level of the CCC and then apply the phaco power and make sure that the nucleus is emulsified. There is a flap motility sign which Dr. Rohit Om Prakash has shown in the American Society, and that had got an award. It means if you notice the flap of the CCC is fluttering in front of your eyes, that has not gone till the equator and beyond. If it has gone beyond the equator, the flap will not motilate. There will be no motility of the flap will be very taut. If the flap turns inwards, that means it has gone to the PC and the rent has happened. This is a bimanual IA. Preferably remove the subincisional cortex first because that's where the CCC is intact. Go ahead and then remove the rest of the cortex. Only in the area of the flap where it's given way, one has to be a little careful to make sure that you don't hold the flap by mistake, because that itself can cause traction on the CCC and pull the zonules. So at this stage, I'm just making sure that all the cortical matter is removed. Once the cortical matter is removed, you'll see the two flaps, and throughout the process, the flap has been motile. It's just flapping up and down, and that means the tear has just reached the equator. It's not gone beyond the equator and not gone to the posterior capsule. And if it had gone to the posterior capsule, this will be a taut flap and it will not be motile. In fact, the margins of the flap would be turned in. This is proven by Dr. Rohit Om Prakash in his presentations many, many times before. So this is complete cortical removal. Now I want to put the lens in the bag. The leading haptic goes in the bag. And the trailing haptic, I don't want to dial this lens because I want to make sure that the area of the tear does not extend beyond that area. So here I try to gently place it behind and into the bag. I'm not sure whether the superior haptic has gone because it's gone, I think, into the sulcus. So now I make the lens horizontal. We all want to put our IOLs horizontally in the bag to prevent dysphotopsia. I re-inject viscoelastic, make sure it goes a little deeper, and now I do a bimanual technique to make sure that the haptic, that's the superior haptic, is in the bag or not. So I made the lens horizontal. Now I'm holding it. Now what I'm doing is I've brought the haptic into the AC because I'm not sure. So this way I brought the lens back, the haptic back into the anterior chamber. And now with the bimanual technique, so I've taken a Sinskey hook in my left hand, going ahead and holding the haptic gently, depressing the optic at the same time, and making sure that it just goes below the margin of the CCC at that level. So this makes sure that your IOL is in the bag in spite of you leaving. Now I'm going ahead and checking where has it gone till. So you can notice that you can see the tear in the CCC, but it's only till the equator. Behind the posterior capsule is fine and everything has gone well. So even if you have a tear in your CCC, look for the flap motility sign and you can still go ahead and do a safe phacoemulsification without any issue. Gently, of course, at this stage, just remove the viscoelastic from in front of the IOL and behind the IOL, and you can see that the flaps come closer and everything has gone well. So even if you have, this was because of the high pressure, the high lenticular pressure, such a complication can happen. I've just shown a way how one can do safe phacoemulsification and get away without any complication at all. Of course, if the flap motility sign was not there, the things would be very different. So this is the first case that I'm showing.
Okay,
Kumar,
that
thank you,
was
Chitra.
a
Thank you very
wonderful
much.
video. That was a wonderful video and a lot of learning for all of us. And I'm heard, and I'm sure all of us know he has shown us all the tenets and all the principles which have to be followed. But I have a question for you, Dr. Kumar. Are you sure there was no capsule tag when you say felt that extension happening?
No,
Was
no.
your capsule Rhexis intact at that point?
Yes, yes, yes. Rhexis was absolutely intact. It was round. So what has actually happened, it was a 4.5 millimeter Rhexis. And if you tend to put a heavier viscoelastic in the center, and when we do a hydro procedure and you don't decompress the nucleus, there's no breaking of the equatorial cortical adhesions. Now that builds up the lenticular pressure so much that the second fluid wave actually made the whole anterior capsule tear across and all the fluid came out. So there was no tear before we did that procedure.
There could have been one more way of dealing with this moment. Probably sometimes you could even change the location of your incision. Like if
Yes.
it's temporarily, then this extension would come subincisionally, and you
Yes.
would find that the fluid wave would not go behind the Rhexis extension, would not go up to the posterior capsule. That's one way of dealing. When would you decide that you are not going to do a Phaco, you're going to convert to SICS? Have you ever been caught in a moment when you've had a Rhexis extension like that?
Yes, so if we, as I mentioned in my talks, if what you said is correct, but here I'm sitting superiorly and I'm operating superiorly, so the tear was inferiorly. So I made sure that my phaco tip throughout the procedure was not in the direction of the tear and it was little away from there. That's step one precaution I took. As far as what you said is, yes, this can happen, but you have to look at the motility sign. So if you feel that the flap motility is absent, it is taut, okay, it's completely taut and the flap refused to move. If the tear extends beyond the equator into the PC and almost towards the center, sometimes the flap margins turn in. And that will say that yes, now whole scenario will change and your whole approach will change. It all depends on whether the nucleus is sinking. If it sinks, then you do a pars plana. If it doesn't sink, it all depends on what stage this happens and how the nucleus behaves.
Dr. Susan, I find Kumar is literally swearing on the slap motility sign every now and then. Do you think that you could have an inverted fluttering flap and you would be so confident and continue a Phaco being sure that it would not extend at all? Or do you have any other question regarding Kumar's case? Or do you think he has justified himself quite well?
I think he's done a pretty good job there, managed it well. Flap motility sign is something that I would definitely pay a lot of attention to. It has been shown to lead you in the right direction, when you're wondering whether the tear has actually stopped short of the equator or whether it's gone around. And I think it is definitely a wise decision to pay attention to that sign and, continue your surgery depending on that.
Does anybody else
Uh,
have anything to add at this point? Yes, Harshul?
I think that was a wonderful demonstration, Dr. Kumar, as if how to proceed with Phaco in case you have an anti-capsule tear. And I think the key in those cases is, of course, to maintain a closed chamber, as you also showed. So whenever you are taking out your Phaco probe, you should put OVD first from the side port, may let the chamber be maintained, and then you come out. The same way, once you finish the irrigation aspiration of the cortical matter, if you need to change the hands, again you go and put OVD. So it can't be emphasized more that it's very crucial to have the deep anterior chamber, because if there is any anterior chamber collapse, that can extend the tear then and there into the posterior capsule. That's
I
very
think
natural.
we are well within time, Dr. Rohit.
Yeah,
Can we take
one
one more
question
question?
was
Okay.
there.
Okay.
How would you change your parameters
No,
for this particular case as compared to a routine phaco that you would have? So noticing that there is a tear in the anterior capsule.
So what I would do is reduce bottle height. And that's the most important thing. And as mentioned by Harshul, is to continuously make sure that you fill the chamber well. Once you reduce the bottle height, with new machines, I'm really not worried about the rest of the fluidics. My vacuum remains 500. I don't think I'll reduce my vacuum because if the occlusion is not there, the vacuum is really not going to act. And as far as the flow rate is concerned, I don't think that's a bigger issue at all. So main important thing is the bottle height. If I reduce the bottle height, I'll see if there is any surge happening in this thing. If the surge happens, I'll play with my flow rate. If there's no surge, and that's all I'm going to do is just reduce the bottle height.
I
My
think,
normal bottle height is.
Can I just add a comment here?
Yeah.
There are two things. One question which Dr. Chitra had posed was, would you like to convert to a non-phaco technique?
Yeah.
Now, there is one situation where I feel one should seriously think about converting to a manual SICS technique, and that is if you're dealing with associated comorbidities. When you have a very hard nucleus, you have a shallow anterior chamber, and the endothelial status is not good. So that is the situation I'll seriously think about not going ahead with phaco and do a non-phaco technique. Second point, Kumar, is it possible to first release the entire lens in the anterior chamber and in a very guarded and controlled manner tuck the haptics under the Rhexis margin so that you don't really have to rotate the lens?
It's possible, but as you notice, I did not rotate it. I put the inferior haptic straight into the bag and then rotated anti-clockwise instead of clockwise. Normally we rotate the lens clockwise. Here I rotated it anti-clockwise and made sure that the haptic which has gone into the bag is made horizontal. And that's the reason why the trailing haptic went straight into the bag after I dialed it and then bring in the anterior chamber. So I did not rotate this lens clockwise, what we normally do in our procedure.
Very well managed.
Oh,
yeah.
very well. Shall we go on to your Kumar's second video?
Thank
the
you.
one on intraop meiosis.
Yes.
One question before, there was a question that can you put in a premium IOL if there is a
Yes.
tear?
Easily.
A toric?
Yes.
Not sorry.
So no, it's controversial. No, but I would still go ahead and put a toric. Only thing different that I feel will happen is, see here the capsular phimosis is not going to be a fear. PCO and movement of the lens may be there,
Yes.
but I will still put a toric in such cases.
I wouldn't though. So what's happening? We go on to the next.
So let's go on to the next.
Mr. Puneet.